I want to ask you a question right up front. Have you ever, looked at someone or maybe even caught a glimpse of yourself in the mirror and thought of that old phrase, getting long in the tooth?
Oh, yeah. I mean, it's one of those idioms we just throw around so effortlessly to describe someone getting older, right?
Exactly. It conjures up this vivid image of like a weary, aging horse
Yeah.
or just a person whose gums have inevitably pulled back.
Right, exposing the roots of their teeth.
Yeah, and we just view it as a sheer, unavoidable consequence of the calendar turning another page. We accept it as gospel.
We really do. We think, well, gravity wins, time wins, our bodies just sort of retreat and dissolve over time.
But what if I told you today that we are going to completely dismantle that idiom, like tear it down entirely?
I am so ready for this.
Because what if the phrase getting long in the tooth is actually based on a massive systemic misunderstanding of human biology?
It's a fascinating premise, honestly,
Yeah.
because it challenges something we have essentially hardwired into our cultural understanding of aging.
Right.
We constantly conflate time with damage. We just assume that because a tissue has been around for, 7, 8, or 9 decades, its deterioration is pre-programmed.
Like it's absolute and unavoidable.
Exactly. But when you actually look at the histology, when you get down to the cellular and biochemical level of the periodontium, that fatalistic narrative completely falls apart.
And for anyone listening, the periodontium is just the specialized tissues that surround and support the teeth.
Yep, the gums, the bone, all of that.
Well, getting down to that exact cellular level is precisely what we are doing for you today in this deep dive.
And it is highly specialized.
Highly specialized, intensely detailed, and honestly incredibly empowering by the time we reach the end of it.
I completely agree. It really changes how you view your own body.
So we're basing our entire conversation today on a meticulously crafted 15-slide masterclass presentation.
And the title of this deck is, let's see, Aging and the Periodontium, Histology, Host Response, and Clinical Treatment Realities.
It is a phenomenal piece of educational material. It doesn't just skim the surface.
No, not at all. It forces you to look at the microscopic architecture. I mean, the gums, the bone, the ligaments, the cementum.
And critically, it asks you to draw a hard, definitive line between what is natural, physiological adaptation and what is actually just, well, cumulative, untreated disease.
Right, which are two very different things.
Exactly. And because this material is so dense, our core mission today is to break down this presentation slide by slide, word by word.
We want to make the complex histology incredibly easy to grasp for you.
The ultimate goal, the finish line we are running toward here, is to learn how to perfectly separate pure, natural aging from cumulative inflammatory disease.
Which is the key to everything.
It really is. And a quick note on the format for you. To make sure we don't miss a single drop of insight, I'm going to guide us through this deck systematically.
Which is definitely the best way to tackle this.
Right. So every time we move to a new slide in the presentation, I will announce it so you can follow right along with the structural logic of the masterclass in your mind's eye.
I think that rigorous approach is essential here. It leaves no stone unturned.
Absolutely.
We're going to build this understanding logically, starting from the basic anatomical foundation, moving up to the systemic immunological responses, and finally, the clinical realities.
Okay, let's unpack this right from the start. We are looking at the very first slide of the masterclass.
The title is big and bold.
Yeah, Aging and the Periodontium, the masterclass. Histology, host response, and clinical treatment realities. The center of this slide is dominated by this highly detailed anatomical cross-section.
It's a cross-section of a tooth and its surrounding periodontium.
But it's split right down the middle, like a before and after photo. It's labeled as an anatomical cross-section, tooth and periodontium, with an arrow pointing to the physiological aging process as you move from the left side of the screen to the right.
This visual split is the perfect starting block, really. It establishes the baseline immediately.
Because you can't understand aging if you don't know the baseline.
Exactly. You simply cannot understand the aging process if you don't know what the young baseline tissue looks like. The left side represents the pristine, youthful state.
And the right side.
The right side shows us what pure time, and critically, time without disease, does to those exact same cellular structures.
Okay, let's do the word-by-word breakdown of these labels. Starting on the left, the young side.
Sure.
Pointing to the gum tissue, it says, healthy young gingiva, thin, regular, resilient. Then, pointing to the bone surrounding the tooth root, it says, young alveolar bone, dense, high cellular activity.
Notice the specific terminology there. Thin, regular, resilient for the gingiva implies a highly efficient, rapid cellular turnover.
Like it's constantly refreshing itself.
Exactly. The tissue is flexible, highly vascularized, and quick to replace itself. And for the alveolar bone, high cellular activity is the key phrase.
Meaning it's busy.
Very busy. Young bone isn't just a static rock. It is constantly remodeling itself. Osteoblasts are building matrix. Osteoclasts are absorbing older matrix. It's a very dynamic, buzzing construction site.
Okay, now let's look at the right side of the split, representing the physiological aging process. Pointing to the layer right on the root of the tooth, it says, older cementum, significant physiological thickening, and in parentheses, warm ochre.
Yeah, in the illustration, you can actually see this thick, warm, ochre-colored layer clinging to the root that isn't nearly as prominent on the young side.
Wow, okay. Next, pointing to the gums. Healthy, older gingiva, fibrous, slightly thicker, well-maintained attachment. And finally, the bone. Older alveolar bone, increased density, reduced cellular turnover, stable height.
This is where the paradigm shift begins for the listener. Look closely at that description of the older gingiva.
It says fibrous, slightly thicker.
Exactly. It did not shrink. It did not recede. It actually got a bit thicker and more heavily cross-linked.
Wait, really? It gets thicker?
Yes. And critically, it has a well-maintained attachment. The gum is still hugging the enamel exactly where it should.
That's wild. And the bone.
It has reduced cellular turnover, meaning the microscopic construction site has slowed its pace, but it explicitly states stable height.
So the bone hasn't melted away just because the person celebrated their 75th birthday?
Not at all. It is so counter to what we implicitly expect.
It really is. And down in the bottom right corner of this first slide, there's a box labeled Exam HUD. I'll read it exactly. Core focus. Differentiate pure physiological aging from cumulative inflammatory disease.
That is the thesis statement for this entire deep dive.
Pure aging versus cumulative disease.
Right. If you take away nothing else today, it is that fundamental distinction. Physiological aging is the thickening cementum, the slightly more fibrous gum, the denser bone, its adaptation.
And cumulative inflammatory disease.
That's the bone lofts, the receding gums, the loose teeth, the deep periodontal pockets. They're absolutely not the same thing, even though they often occur simultaneously in an older person.
Our clinical job is to decouple them in our minds.
Exactly.
Now come into the next slide.
This is where we hit the cultural myth head on.
We really do. Slide 2 is visually striking. Right at the top, in massive, bold red letters, is a stark equation. Age equals attachment loss.
But there is a thick, aggressive black strike-through line cutting right across it.
Yeah, it is entirely crossed out. And below it, in solid green text, is the corrected, scientifically accurate equation. Time plus, in parentheses, plaque plus trauma equals attachment loss.
That visual of crossing out the red text is so necessary. Because for decades, even within the broader dental and medical communities, there was a quiet, almost fatalistic acceptance that age itself was the primary driver of losing that periodontal attachment.
Just a given.
Right. But the green equation tells the true biological story. Time alone doesn't sever the attachment. Time is just a multiplier.
It just provides the opportunity.
Exactly. Time provides the opportunity for plaque and physical trauma to do their cumulative damage.
Let's read the text below that word by word to really lock this in. Under the heading, The Reality, it says, gingival recession is not an inevitable physiologic process of aging.
Amen to that.
And then, under the heading, The Culprits, it lists exactly what is responsible. It says, cumulative exposure to plaque-associated periodontitis, aggressive toothbrushing trauma, and iatrogenic damage. And it lists unfavorable restorations and repeated scaling in parentheses.
Let's unpack that last part. Plaque-induced inflammation and brushing too hard with a stiff bristled brush, I think most people understand.
Right, brushing too hard makes sense. But let's dive into iatrogenic damage. What is that?
Iatrogenic is a medical term that essentially means caused by the healer.
Oh, wow.
Yeah, it refers to tissue damage or complications that result directly from medical or dental interventions.
So the treatment itself causes the harm.
Right. In this context, unfavorable restorations might mean a filling, a veneer, or a crown that has a rough overhanging margin right at the gum line.
Like a little ledge?
Exactly. That microscopic ledge creates a sheltered harbor where bacterial plaque can constantly hide, mature, and irritate the surrounding gingiva day after day, year after year.
That sounds miserable for the gums. And what about repeated scaling?
That refers to overzealous professional cleanings. Over decades, if a patient is subjected to aggressive, heavy-handed scraping of the root surfaces time and time again, that repeated physical trauma from the metal instruments can actually induce the delicate tissue to retreat defensively.
I actually have an analogy for this. Tell me if this works to explain the time plus trauma equation.
Go for it.
Okay, it's like looking at an old, beautifully constructed historic house. You walk up to it and you see the paint is severely peeling, maybe some of the wood siding is rotting near the foundation.
Sure, classic old house.
Right, but the paint isn't peeling just because the house was built 80 years ago. It's peeling because it has endured 80 years of freezing rain, baking sun, and high winds.
Oh, I like this.
Age, or chronological time, is just the metric of how long the house has been exposed to the storm. If you took that exact same house, built with the exact same materials, and put it inside a climate-controlled protective dome for 80 years, the paint would still look pristine.
That is a perfect analogy. The sheer age of the wood didn't cause the rot. The moisture and environmental trauma over time rotted the wood.
Exactly.
In the human mouth, age doesn't cause the gums to recede. The chronic presence of bacterial biofilm, the daily overzealous scrubbing, the poorly contoured fillings that is the storm.
The storm causes the damage.
Can cause the recession over time.
At the bottom right of this slide, there is a mnemonic box to help us instantly recall this principle in a clinical setting. It says, fact, false assumption that connective tissue universally recedes with age alone.
FACT. False assumption that connective tissue universally recedes.
It's catchy.
It's brilliant because it forces a clinician to actively challenge their ingrained cognitive bias every single time they examine an older patient with recession.
You can't just blame it on them being old.
Exactly. You have to stop thinking, well, they're 75, of course their roots are showing. And you must start investigating what precise mechanism has been traumatizing this specific area of tissue for the last 50 years.
Now coming to the next slide.
We're shifting gears slightly here to look very closely at the surface tissues.
Specifically the gingival epithelium, right?
Yes, and a really fascinating, somewhat counterintuitive anatomical phenomenon called passive eruption.
The title of slide 3 is Gingival Epithelium and Passive Eruption. There is a bulleted list under histologic shifts. It reads, conflicting data on thinning/keratinization, broad consensus on flattening of vape pegs, altered cell density.
Okay, we need a serious deep dive right here on reed pegs.
I was just going to say, as we establish, we want to know the how and why. What are these reed pegs structurally, and why does a broad consensus on their flattening matter so much?
To visualize this, imagine interlocking your fingers together tightly, pressing your two hands against each other.
Okay, like folded hands.
Right. That wavy, undulating, interlocked boundary is incredibly strong, right?
Yeah.
It resists shearing forces like sliding apart much better than if you just pressed your flat palms together.
Oh, absolutely.
In the human gums, the outer protective layer, the epithelium, and the deeper vascularized layer, the connective tissue, do exactly this.
They interlock.
Yes.
Mhm.
The epithelium sends these little undulating cellular fingers down into the connective tissue. Those interlocked fingers are the reed pegs.
Oh, okay. I get it.
They massively increase the total surface area for structural anchoring. And critically, they increase the surface area for the basement membrane, which is where nutrient exchange happens between the blood vessels below and the non-vascular epithelium above.
So as we age, the histological consensus is that these vital interlocking fingers, these reed pegs, begin to flatten out.
Exactly right. The boundary goes from being highly weighty, deeply interlocked and complex to being much more linear and flat.
So the anatomy literally shifts from interlocked fingers to flat palms pressing together.
That's the exact shift.
What does that mechanical change mean for the tissue practically?
It means the tissue is potentially far more vulnerable to mechanical shearing forces.
Ah, so it tears easier.
Basically. If you brush aggressively or if you eat something sharp and hard like a tortilla chip, that outer layer of gum tissue doesn't have the same robust, deeply anchored mechanical resistance to the tissue underneath it. It's slightly more delicate in terms of resisting friction.
That makes total sense.
Furthermore, because that basement membrane surface area is significantly reduced by the flattening, the metabolic efficiency and nutrient transfer to the outer layers might subtly shift. It's a slow change, but it's a universally agreed upon microscopic hallmark of aging tissue.
Okay, that structural logic makes total sense. Now let's look at the diagram and the flowchart on the bottom half of this slide.
This explains the passive eruption sequence.
Right. The flowchart reads, tooth surface loss from attrition, arrow pointing to. Tooth erupts to maintain occlusal contact, arrow pointing to. Dentogingival complex moves coronally.
Let's translate that out of the textbook jargon and into everyday biomechanics.
Please do.
Attrition is the physical wear and tear on the biting surfaces of your enamel over decades of chewing, grinding, and speaking.
Just normally use.
Right. As you slowly wear away the enamel on the top of the tooth, your upper and lower teeth would theoretically stop touching each other when you bite down. You'd lose your bite force.
Because they're getting shorter.
Exactly.
Yeah.
But the human body is incredibly adaptive.
It fundamentally wants to maintain that biting connection, that occlusal contact, right?
Precisely. So to actively compensate for the microscopic wear on the top, the entire tooth slowly, over decades, erupts slightly further out of the alveolar bone.
It pushes out.
Yep, it pushes upward to meet its partner tooth on the opposing arch. This biological movement is called active eruption.
Okay.
But the crucial part, the part that addresses our aging myth, is what happens to the surrounding gums when the hard tooth moves. The entire unit of supporting soft tissue, the dentogenal complex, moves coronally, meaning it moves upward, toward the chewing surface of the tooth, right along with it.
Wow. And that biological reality leads directly to the exam parole box on this slide, which I am so eager to read because it completely shatters the long in the tooth illusion.
It really is a mind bender.
It says, counterintuitive board question. With passive eruption, the width of the attached gingiva actually increases with age. It does not decrease.
It is the ultimate trick question because it defies every assumption we make about aging mouths.
Why does it increase?
Because the tooth is slowly erupting outward to compensate for enamel wear, and the attached gum tissue follows it upward. But the bottom boundary of that gum tissue, the mucogingival junction where it meets the loose, movable tissue of your cheek, stays anatomically stable.
Oh. So the top moves up, but the bottom stays put.
Exactly. So the actual band of thick, attached pink gum tissue is forced to stretch and get wider. Mathematically, you actually gain a wider zone of attached gingiva as you age naturally.
So not only are your gums not biologically programmed to shrink and vanish as you get older, they actually mathematically have to expand and get wider to compensate for tooth wear.
It's brilliant, isn't it?
That is absolutely astonishing, and it completely rewrites the narrative. Now, coming to the next slide.
The slide takes all of that pristine physiological theory and forces us to apply it to stark, visual, clinical reality.
Slide 4 is titled Clinical Scenarios of the Gingival Margin. There is a massive blue box across the top that establishes a firm baseline for everything that follows.
And it's an important baseline.
It reads, Diagnostic rule. Anatomical variations and lifelong habits dictate margin position, not chronological age. Below this overarching rule, we have 3 incredibly clear, highly magnified clinical photographs of patients' teeth and gums, simply labeled A, C, and D.
Let's act like clinical detectives looking at these
I
photos.
love that.
We have the underlying rules of physiological aging and passive eruption in our heads now, so let's see how those mechanisms manifest in real, living human mouths.
Okay, let's start with image A. The caption reads, Older patient, over-eruption with recession, history of periodontitis.
Okay, what do we see?
The photo shows mandibular front teeth where the gums have pulled drastically back, exposing a significant amount of the yellowish, opaque tooth root. You can clearly see the dark, empty triangles of space between the teeth where the papilla has vanished.
When the average person thinks of aging, this is the classic long-in-the-tooth presentation they picture.
For sure.
But notice the critical context in the caption. It doesn't just say older patient and leave it at that. It explicitly notes a history of periodontitis.
Oh, right, the disease.
Exactly. This patient suffered from active, bacteria-driven inflammatory disease over their lifetime. That inflammation triggered osteoclast to destroy the supporting bone, and the gum tissue followed the bone down.
So they receded.
Yes. The teeth over-erupted, they grew outward due to attrition, but the gums receded violently in the opposite direction because of the disease process. This is the cumulative inflammatory disease we highlighted as the core focus on slide 1.
Right. It's the storm damage on that old house we talked about.
Perfectly said.
Now contrast that violently with image C right next to it. The caption says, Older patient, over-eruption without recession, migrated coronally.
Look closely at that one.
In this photo, the teeth clearly look older. The biting edges are flattened and worn down, but the gums are thick, highly stippled, robust, and they come all the way down to cover the roots perfectly, exactly at the enamel junction. There is zero recession.
This image is the absolute biological proof of concept. This is the house that was kept out of the storm for 8 decades.
Wow.
This older patient experienced the natural, Physiological wear and tear the attrition, and their teeth passively erupted outward to maintain their bite.
And the gums moved with them.
Yes.
Yeah.
Because they maintained pristine hygiene and did not have a history of destructive periodontitis or aggressive traumatic brushing, the gum tissue did exactly what we learned on the last slide. It moved right along with the tooth. It migrated coronally.
That's incredible.
This single clinical picture irrefutably proves that chronological age alone does not guarantee attachment loss.
And then we look at the final piece of the puzzle, image D, the caption. Younger patient, extensive recession, thin anatomy, plus toothbrush trauma.
Right, a totally different scenario.
Here we have a clearly young mouth. You can tell by the pristine, untouched enamel and the complete lack of incisal wear, but the gum tissue has severely and dramatically receded on one of the prominent front teeth, completely exposing the root surface.
This perfectly completes our diagnostic logic.
Yeah.
Why on earth does a 25-year-old have the recession of a 70-year-old?
Because of the equation, time plus plaque plus trauma.
Exactly. This young patient has what we call a naturally thin biotype or periodontal phenotype. Their gingival tissue and the underlying bone on the facial aspect of the tooth are just genetically exceedingly thin and delicate.
So they're already vulnerable.
Yes. Coupled with that anatomical vulnerability, they likely scrubbed far too hard with a stiff toothbrush. The sheer mechanical trauma was so intense that it caused catastrophic attachment loss rapidly.
Even though they're young.
Right. It required very little time because the trauma variable was so incredibly high.
There's a yellow clinical tip box on the bottom right that summarizes exactly the diagnostic mindset you just walked us through. I'll read it. Recession in a 30-year-old. Suspect thin biotype or trauma. Recession in a 70-year-old. Assess cumulative inflammatory history. Age is never the primary diagnosis.
Age is never the primary diagnosis.
Yeah.
That is a profound, paradigm-shifting statement for any healthcare provider.
It really changes everything.
It strips away the lazy assumption and forces you to look for the actual mechanical or biological root cause rather than just shrugging your shoulders and blaming the calendar.
Now coming to the next slide.
We're diving deep beneath the surface now.
Going microscopic.
Yep, we're zooming past the outer epithelium and looking directly at the structural scaffolding that holds everything together, the connective tissue.
Slide 5 is titled Gingival Connective Tissue. It features two highly magnified circular microscopic graphics placed side by side for direct comparison.
Let's compare them.
On the left, representing young tissue, which is labeled soluble, we see this elegant matrix of thin, straight, bright green fibers crisscrossing with plenty of interstitial space, and little pink fibroblast cells scattered abundantly throughout.
That's the young scaffolding.
Right. On the right, representing older tissue, labeled insoluble, the architecture looks entirely different. It's a dense, thick, highly wavy, chaotic mass of yellow and orange fibers packed tightly together with almost no space between them. It looks almost like a heavy bundle of thick maritime ropes.
Those visual representations are mathematically perfect for understanding what happens to the biochemistry of collagen over a lifetime.
Okay, break it down for me.
Connective tissue is primarily made of collagen fibers, which provide the tensile strength. In young, highly adaptable tissue, those fibers are delicate, structurally organized, and crucially, they're easily broken down by enzymes and replaced with fresh collagen.
Oh, so that's what soluble means here.
That's what soluble means in this specific biochemical context. The tissue is in a state of rapid, constant remodeling.
But the text under the heading, the collagen paradox, highlights something that seems fundamentally contradictory. I'm going to read it, and then I need you to explain the mechanics of how this is even possible.
Lay it on me.
It says, older gingiva has a lower rate of collagen synthesis, yet overall collagen content actually increases. Wait, that feels paradoxical.
It really does.
Right. If the fibroblast activity drops and they're making less collagen, shouldn't we see a thinning or a depletion of the connective tissue? Why is it actually getting denser and increasing in overall content?
It's a brilliant paradox. Think of it like a massive distribution warehouse.
Okay, a warehouse.
In a young, highly efficient warehouse, new inventory is constantly arriving on trucks, but old inventory is also constantly being shipped out, sold, or thrown away. The turnover rate is incredibly high.
So it never gets overpacked.
Exactly. The warehouse is never overly full because the intake and output are perfectly matched. But in an older warehouse, the deliveries slow down drastically. The manufacturing factories are making less new inventory.
Right, fewer fibroblasts.
Yes. But crucially, the workers inside the warehouse stop throwing the old, obsolete inventory away. The garbage disposal system fails.
Oh, wow.
So the old boxes just sit there, accumulating, getting pushed to the back, piling up to the ceiling.
So it's a failure of the breakdown process. The output stops matching the input.
Exactly. The biochemical text on the slide explains the specific mechanism of this warehouse failure. Let's look at biochemical shift.
Okay, it says, increased conversion rate from soluble to insoluble collagen. Tissues become coarser, denser, with increased mechanical strength and a higher denaturing temperature.
Right. Over time, the individual collagen molecules form deeper, tighter, highly complex cross-links with each other, often driven by accumulated advanced glycation and products.
So they get tangled up.
They convert from that fresh, easily digestible soluble state into a stiff, highly resistant insoluble state.
And the body can't break it down.
The body's natural enzymes that normally act as the garbage disposal to chalk up old collagen, they're called matrix metalloproteinases, or MMPs, simply cannot easily cleave this new, tough, highly cross-linked insoluble structure.
So it just builds up.
Yeah.
Right.
So even though your fibroblasts are synthesizing far less new collagen, the old, hardened collagen is piling up and refusing to be degraded.
So the tissue literally becomes tougher and more rugged. The slide says increased mechanical strength and a higher denaturing temperature. It literally takes more thermal energy, more heat to break the protein bonds apart.
Yes.
It's like the physical difference between a fresh, green, bendable willow twig and a dried out, hardened, inflexible oak branch.
That's right. It becomes remarkably coarser and denser. Now, biologically, it isn't necessarily better because it loses some of its youthful elasticity, vascularity, and rapid healing resilience. But it certainly isn't melting away or vanishing.
Yep.
It is physically accumulating.
And there's a mnemonic box here to lock this complex biochemistry in. Mnemonic, old collagen is CDI, coarser, denser, and soluble. That's a great, quick, cognitive reference to remember exactly why the older tissue under the microscope looks like those thick, impenetrable yellow ropes. Now coming to the next slide.
We're moving progressively deeper now.
From the connective tissue to the ligament.
Yes. We've gone from the gums to the connective tissue, and now we are descending into the tiny microscopic gap between the hard tooth root and the hard jawbone, the incredibly vital home of the periodontal ligament.
Slide 6 is called periodontal ligament dynamics, or PDL dynamics. The diagram shows the tooth suspended in the bony socket, with detailed calap bubbles magnifying the extremely thin space between the root surface and the alveolar bone.
It's a very tight space.
There's a box on the right titled Cellular Decline Summary, and the bullet points are quite stark. It lists decreased fibroblasts, decreased organic matrix production, decreased epithelial cell rests of molasses, and more irregular structure overall.
A lot of declines.
Yeah, this sounds like a cascade of cellular bad news. Can you translate some of these specific cellular components? What exactly is failing or declining here?
Let's break down the workforce. Fibroblasts, as we just discussed with the gingiva, are the primary builder cells. They are the dedicated workers in the local factory, spinning out the collagen fibers and the surrounding organic ground substance that makes up the ligament.
So decreased fibroblasts just means fewer workers.
Exactly. Decreased fibroblasts and decreased matrix production means the active, capable workforce in the ligament has simply dwindled with age. As a result, the architectural structure becomes a bit more irregular, less pristine, and a bit more chaotic.
Okay, what about those epithelial cell rests?
Those epithelial cell rests of molasses, which is just a fantastic classic historical anatomical name, are essentially dormant, leftover clusters of cells from when the tooth was originally forming in the embryological jaw.
What do?
Their exact day-to-day function in the adult ligament is still highly debated among researchers, but we know definitively that their sheer numbers decline significantly as we age. Overall, the cellular vibrancy and reproductive capacity of the ligament inevitably drops.
But then, looking at the graphic at the bottom of the slide, there's a diagram showing a mechanical slider. It says, width dictated by functional load. Hypofunction equals narrow. Excessive load equals wide.
That's the biomechanical
But
point.
what does the functional demand have to do with the physical width of this microscopic ligament?
Everything.
Yeah.
The periodontal ligament is not just a static piece of biological tape. It is a highly dynamic, sensory-rich shock absorber for the tooth.
A shock absorber.
Yes. It holds the tooth tight in the bone, but allows for tiny, critical micro-movements when you chew, absorbing the immense forces of your jaw muscles. Through a process called mechanotransduction, the cells in the ligament actually sense the physical strain and adjust the tissue.
Wow.
The width of that shock absorber isn't determined by how old you are. It is determined entirely by how hard it has to work. If a tooth loses its partner on the opposite jaw and doesn't have an opposing tooth to bite against, that's what we call hypofunction, the ligament gets very narrow, thin, and atrophic because it simply isn't being used. It's exactly like a bicep muscle atrophying when your arm is in a cast.
But if it works too hard?
If a tooth is taking an excessive load, maybe from chronic nighttime grinding or a heavy, unbalanced bite, the ligament actually widens and thickens significantly to try and dissipate and accommodate that immense mechanical stress.
So the physical demand of the local environment dictates the anatomy, not the calendar year.
Precisely. And that biomechanical reality leads to the really critical exam pearl on this slide.
Yes, let me read the pearl because it perfectly bridges the gap between the lab and the patient. It says, age decreases PDL cell proliferation and repair potential in vitro, but this impairment rarely manifests clinically. I love this distinction so much.
It is the fundamental difference between abstract laboratory metrics and real physiological capacity.
Right. It makes me think of a mechanical analogy.
Hit me.
It's like taking the engine out of a beautifully maintained, classic 1960s car, putting it on a sterile test bench in an engineering laboratory, and running all these highly sensitive diagnostic metrics on it.
Testing all the specs.
Yeah. You measure the absolute peak horsepower, the micro torque, the cylinder compression, and you write a report saying, well, compared to a brand new 2024 engine straight off the assembly line, this old engine has decreased proliferation, its repair potential is lower, the absolute metrics are objectively worse.
Right.
That's the in vitro part in the glass, in the petri dish, in the lab. But then you put that engine back into the classic car and you drive it down the highway to the grocery store and it runs beautifully. It gets you there at 65 miles an hour without a single sputter or hesitation. That is the clinical manifestation.
I absolutely love that analogy. It captures the essence of this slide perfectly.
Yeah.
The older fibroblasts in a sterile petri dish might look sluggish. They might be slow to divide under a microscope. Their theoretical absolute ceiling for rapid repair is demonstrably lower.
But in the real world.
But in the actual human mouth, doing the daily, real-world job of chewing food and maintaining the integrity of the tooth socket, that slightly lower ceiling is still far, far higher than what is actually needed to get the job done flawlessly. The cellular impairment is an academic reality, but it's a clinical non-issue.
It's such a profoundly reassuring message. Your body might not look perfect under a scanning electron microscope, but it is still fundamentally capable of performing its required duties. Now coming to the next slide.
This next slide is where we truly lift the hood on the systemic immune system and look at the invisible biochemical text messages that control the fate of your jawbone.
Oh, this is the homeostasis one.
This is where the sheer evolutionary magic of homeostasis happens.
Slide 7 is titled Bone and PDL Homeostasis, the Cytokine Balance. The main visual dominating the slide is a large, classic balance scale, like the scales of justice.
What's on each side?
On the left side of the scale, sitting heavily on a red platter, is a box labeled pro-inflammatory threat. Under it, it lists increased IL-1, IL-6, ARNC-LL.
And the right.
On the right side, sitting on a green platter, is a box labeled protective antagonist. Under it, it lists increased OPG, osteoprotogerin. And despite the heavy weights on both sides, the scale is perfectly horizontally balanced.
To truly grasp the gravity of this slide, we have to talk about cytokines.
What are they exactly?
Cytokines are essentially the biochemical text messages that immune cells send to each other to coordinate a response. Some text messages say, start a fire, we have an invasion, destroy the surrounding tissue to trap the bacteria. Those are your pro-inflammatory cytokines.
Like IL-1 and IL-6.
Exactly. Other text messages say, calm down, the threat is handled, build things back up, protect the structural integrity. Those are your anti-inflammatory or protective cytokines.
Let's do the word-by-word breakdown at the bottom of the slide to see how this invisible text message battle plays out specifically in aging tissue.
Okay.
First, the threat. PDL cells in older individuals greater than 60 years express greater pro-inflammatory cytokines, activating osteoclasts.
Okay, so this is the alarming part. As we age, the baseline level of start a fire text messages naturally drifts upward. The cells in older periodontal ligaments naturally secrete more interleukin-1, or IL-1, and interleukin-6, or IL-6.
Those are the inflammatory ones.
Yes, these are famous, highly potent systemic inflammatory markers. And crucially, they express much higher levels of a protein called arancalo.
What does RNCal do?
Arancal is the specific targeted biochemical key that unlocks and activates osteoclasts. And osteoclasts, as we mentioned earlier, are the specialized multinucleated cells that literally secrete acid and enzymes to eat and dissolve your bone.
Wait, so the inherent threat is that the aging process naturally turns up the volume on the exact signals that destroy your jawbone.
That's the threat, yes.
That sounds absolutely terrifying. If that was the end of the story, our jaws would just dissolve into mush as we got older.
Thankfully, it's not the end of the story.
Let's read the countermeasure. The defense. The body mounts a homeostatic response by simultaneously upregulating OPG, which antagonizes RNCalo binding.
This right here is the absolute brilliance of human biology. The body isn't stupid. It senses that the destructive signals, the RNKL, are increasing in the local environment. So it doesn't just sit there and let the bone melt.
It fights back.
It actively, aggressively fights back to maintain balance homeostasis. It drastically ramps up the local production of a protective protein called OPG, or osteoprodogerin.
How does OPG work?
OPG acts essentially as a biochemical decoy. It floats around in the extracellular space and physically intercepts and grabs onto the RNKL signals before they can ever reach the receptors on the bone-eating osteoclasts. It entirely neutralizes the threat before it can be executed.
Which leads directly to the result. Balance is maintained, preventing excessive tissue damage despite a higher inflammatory baseline.
Exactly. Both sides of the scale get heavier. The inflammatory threat gets heavier with more IL-1 and RNKL, but the protective defense gets equally heavier with a massive surge of OPG.
The tension rises, but the scale doesn't tip.
Right. The physical scale stays perfectly horizontal. The net result on the actual bone destruction is zero.
And the exam pearl at the bottom of the slide drives this home with a perfect mechanical metaphor. OPG acts as the biological brakes on bone resorption. Its concurrent rise with IL-1, IL-6 protects the aging periodontium.
Biological brakes.
I just marvel at the idea that our bodies have these built-in, highly sensitive biological brakes that automatically pump themselves harder and harder when the car starts naturally accelerating down the aging hill. It's an incredible self-regulating, fail-safe defense mechanism. Now coming to the next slide.
We have thoroughly discussed the soft tissues, the ligaments, and the invisible chemical balance of the bone. Now let's look at the physical anatomical changes to the hard tissues themselves as the decades pass.
Slide 8 is cementum and alveolar bone changes. We have a large, detailed diagram of a solitary tooth root.
It's highlighted.
The outer layer of the root is highlighted in that same warm ochre color we saw all the way back on slide 1, labeled thickened cementum. But here we can see clearly that it is very thin near the top of the root, near the crown labeled thin cervical cementum, and it gets massively thick, wavy, and bulbous near the bottom tip of the root.
Cementum is a highly specialized calcified substance. It's essentially the biological glue that covers the entire root of the tooth. Its sole critical job is to provide a porous surface for the periodontal ligament fibers, those shock absorbers we discussed, to embed into, anchoring the tooth firmly to the alveolar bone.
Let's read the cementum realities text box. Deposition is continuous throughout life. Width increases 5 to 10 times, primarily apically and lingually. The surface becomes irregular due to accumulated resorption bays.
Okay, there's a lot there.
Yeah, increasing 5 to 10 times in thickness is a massive, highly visible anatomical change. And it says apically and lingually. For spatial orientation, can you remind us exactly where those directions are pointing?
Absolutely. Apically means toward the apex, or the very deepest tip of the tooth root, buried far down in the jawbone.
Okay, at the very bottom.
Right. Lingually means on the inside surface of the tooth, the side facing your tongue. So this biological glue isn't just thickening evenly, like adding a uniform coat of paint everywhere. It is pooling, adapting, and packing heavily down at the very tip of the root and on the tongue side.
Why does it do that?
This ties perfectly back to our passive eruption concept from slide 3. As the tooth slowly erupts upward to compensate for chewing wear, it would theoretically pull out of the socket and become loose.
Because it's moving up.
Yes. To prevent this, the body continuously deposits huge amounts of cementum at the very bottom, the apex, to fill in the empty space left behind, effectively pushing the tooth up from below while maintaining a rock-solid foundation.
That is so smart. And what about the irregular surface?
Because there is microscopic wear, minor trauma, and repair happening constantly over decades, the surface isn't glassy smooth anymore. It gets lumpy and highly irregular, full of little microscopic divots called resorption bays that have been hollowed out and then filled back in with fresh cementum.
Below that, we have alveolar bone realities. It reads, presents a more irregular periodontal surface with less regular collagen fiber insertion. Crucially, the healing rate in extraction sockets and implant osseointegration is completely unaffected by age.
The first sentence makes total biological sense based on what we've learned so far. The internal surface of the bony socket gets a bit more irregular and jagged, just like the lumpy cementum. The dense, insoluble collagen fibers from the older warehouse aren't inserting in perfect, pristine parallel arrays anymore.
Right.
But that second sentence is an absolute blockbuster for clinical dentistry.
It really is. I'm going to read it again. Crucially, the healing rate in extraction sockets and implant osseointegration is completely unaffected by age.
This destroys another massive, widely held clinical myth.
The brittle bone myth.
Exactly. People, and even sometimes older clinicians, often assume that an 80-year-old patient shouldn't undergo oral surgery or get a dental implant because their old, brittle bones simply won't heal. The masterclass confirms this is completely false.
Completely false.
Yes. The biology dictates that if you carefully extract a tooth, the massive blood clot forms, the osteoblasts rush in, and the hole fills with dense new bone just as successfully and roughly as predictably in a healthy 80-year-old as it does in a vibrant 20-year-old.
That's amazing.
If you place a threaded titanium implant into that jaw, the bone physically fuses to the titanium, a process called osseointegration, with the exact same high statistical success rate, regardless of the patient's chronological age.
So the bone's healing power doesn't drop.
The surrounding bone might be denser, the baseline turnover might be slower, but its ultimate fundamental capacity to heal a wound and integrate a foreign structural body is fully, beautifully preserved.
To help clinicians instantly remember all of these complex dynamics about cementum, there's a mnemonic box at the bottom. Cementum gets FAT, 5 to 10 times thicker, apicolingual accumulation throughout life.
FAT.
I love a memorable acronym. It paints a very clear, exaggerated mental picture of that bulging, ochre-colored layer actively growing at the root tip over a lifetime. Now coming to the next slide.
This is a perfect, highly strategic moment in the masterclass to pause and structurally synthesize the massive amount of microscopic histological detail we just covered.
Absolutely. Slide 9 is titled The Periodontium Age Shift Matrix. It's a remarkably clean, simple visual table comparing the younger profile to the older profile across 5 different specific tissues.
It's a great cheat sheet.
Yeah, there's a yellow study hack box right up front that loudly says, screenshot this matrix. It isolates 80% of the discrete histological changes tested on periodontal board exams. So for anyone listening who loves having all the complex answers distilled into one place, this is your gold mine. Let's quickly review this matrix to really stamp the interconnectedness of everything we've learned so far.
Let's do it. Reviewing this matrix side by side really crystallizes how all these subtle changes happen in concert.
Okay, first row. Tissue, epithelium, younger profile, prominent reed pegs, older profile, flattening reed pegs.
That's the interlocked fingers turning into vulnerable flat palms, decreasing surface area.
Second row. Tissue, gingival connective tissue, younger profile, soluble, fine collagen, older profile, insoluble, dense, coarse.
That's our CDI mnemonic. The factory slowed down, but the garbage disposal fails, leading to tough, dense accumulation.
Third row. Tissue, PDL cells, younger profile, high fibroblast count, older profile, decreased fibroblasts, increased elastic fibers.
The active cellular work source shrinks, but the tissue adapts.
Fourth row. Tissue, cementum, younger profile, thin, regular surface, older profile, 5 to 10 times thicker, epically irregular.
Cementum gets FAT to maintain the tooth in the socket as it wears.
Fifth row. Tissue, alveolar bone, younger profile, regular collagen insertion, older profile, irregular surface, unaffected healing.
That crucial point, the microscopic architecture is messy, but the microscopic healing capacity is utterly untouched.
Reading through that matrix, you can see the grand physiological design. Every single tissue changes. Every tissue must adapt to the passing decades. But none of these specific microscopic changes, flattened pegs, dense collagen, thicker cementum, none of them inherently causally force the teeth to fall out or the gums to dramatically recede.
Right. They're just the benign physiological patina of time.
Now coming to the next slide.
We've spent the entire deep dive so far looking at the human body in a vacuum. Now we have to introduce the ultimate disruptive wildcard into this pristine biological system.
The bacteria.
Yes, the bacteria.
Slide 10 takes us straight into the oral microbiome. It's titled Bacterial Plaque and Microbiome Shifts. We have 2 large distinct circles on the slide. The left circle is labeled supragingival plaque, which means the sticky film of plaque located above the gum line on the highly visible, easily reachable part of the tooth crown.
The plaque you can easily brush off.
Right. Inside the circle is a giant equal sign and the text. No true qualitative differences in composition.
That is a surprisingly straightforward finding. It means that if you swab the smooth enamel of a healthy 20-year-old and sequence the DNA of the bacteria, and then do the exact same thing to a healthy 80-year-old, the primary cast of microbial characters hasn't meaningfully changed.
The same bugs.
Yeah, the dominant species living in the open air of the mouth remain the same across a lifetime.
But the circle on the right tells a very different, far more sinister story. It's labeled subgingival plaque, meaning the plaque hiding deep below the gum line, down in the dark periodontal pockets.
The dangerous neighborhood.
Yes. Inside this circle, there are alarming upward arrows next to enteric rods, pseudomonads, P. gingivalis, and a downward arrow next to A. actinomycetum comitans.
Okay, those are some heavy, specialized microbiology names. Let's focus on P. gingivalis. That specific bacteria is one of the most notorious, aggressive, major players in severe, tissue-destroying gum disease.
So it goes up as we age.
This slide proves we do see a massive, highly dangerous shift in the bacterial population below the gums as people age. The actual types of bugs mutate from relatively benign to highly pathogenic. The critical question for the clinician is, why does the microbiology change so drastically?
The text below the circles, perfectly titled Ecological Determinants, Not Chronology, answers that mystery. I'll read the crucial paragraph. Plaque quantity may increase due to exposed root surfaces from recession, which are harder to clean. Pathogen shifts are likely driven by these altered local anatomical niches and systemic health changes rather than chronological age itself.
This goes back to our earlier analogies, but let's build a new, highly specific one to explain the ecological plaque hypothesis.
I love analogies. Let's hear it.
Think of an ecosystem like a vibrant, sunlit forest. If you have a clean, fast-moving, shallow stream running through it, you get certain types of fish and insects that thrive in high oxygen. That is a young, healthy mouth with tight, shallow gums.
Nice and clean.
But let's say, over decades of trauma, poor brushing, and subtle bone loss, the gums pull away slightly, and the pockets around the teeth get physically deeper. The rough, irregular cementum roots are exposed. Now, instead of a fast, oxygen-rich stream, you have created deep, dark, completely stagnant, oxygen-starved pools.
You've built a swamp.
You've built a swamp. And entirely different, far more dangerous creatures evolved to live in a dark swamp.
That makes total sense.
Exactly. P. gingivalis is a strict anaerobe. It literally cannot survive in the high oxygen environment of a healthy, shallow gum pocket. It requires the dark, oxygen-deprived depths of a diseased pocket to thrive. The exam pearl at the bottom of the slide summarizes this ecological reality beautifully.
It says, age alone does not drastically mutate the plaque biofilm. New niches recession, root exposure breed new flora.
The calendar turning to age 65 didn't magically summon P. gingivalis into the mouth. The changing environment invited them in. The cumulative trauma created deep pockets with zero oxygen and rough root surfaces that are physically impossible to clean with a standard toothbrush.
So you biologically built a swamp and the swamp creatures moved in?
Exactly. It's an ecological shift, driven entirely by anatomical changes that took time to develop, not some inherent biological clock that forcefully mutates your bacteria on your birthday.
That distinction is so critical for treatment. It means you can't just fight the bacteria. You have to physically alter the environment to evict them. Now coming to the next slide.
If the local environment in the mouth is the swamp, we now need to zoom out and look at the systemic, macroscopic weather patterns affecting the whole body. We're moving into systemic immunology.
Slide 11 is immune response and immunosenescence. There's a highly striking, simple line graph here. The y-axis is CRP level and the x-axis is age.
What do the lines do?
There are two distinct lines tracking across the decades. The green line, securely labeled healthy older adults, stays completely flat, hugging the absolute bottom of the graph steadily as age increases from 20 to 80. But the red line, ominously labeled progressive periodontitis, starts low in youth and then violently spikes up and down, trending massively higher and higher as age increases.
CRP stands for C-reactive protein. It is essentially a systemic distress signal flare sent up into the bloodstream by your liver when there is significant inflammation happening anywhere in your body.
So it's a major red flag.
Huge. It's a major, highly watched systemic marker we use in medicine to assess overall inflammatory burden, and it is very heavily linked to severe cardiovascular risk and stroke.
So looking directly at the data on the graph, a healthy older adult does not naturally or inevitably have high systemic inflammation. The green line proves it stays completely flat.
Right.
It's only the patient suffering from severe untreated gum disease whose body has these massive systemic distress flares constantly going off as they age.
Let's read the word-by-word text below to see how the cellular immunology connects to this macro graph.
First bullet. Age has much less effect on host response than previously thought, provided confounding systemic conditions are excluded. Second bullet. Cellular shifts exist in T, B, and NK cells alongside increased M1 or inflammatory macrophage subset gene expression. Third bullet. Nutrition. Lower serum folate is negatively associated with periodontitis in adults greater than 60 years.
Let's unpack the cellular biology there. The first bullet is the overwhelmingly good news. If you don't have uncontrolled diabetes, severe cardiovascular disease, or other massive systemic confounders, your immune system's basic fundamental capacity to respond to the bacteria in your mouth remains incredibly robust, well into old age.
Good.
The second bullet acknowledges the reality of immunosenescence, that yes, the specific subtypes of immune cells, like your T cells, B cells, and natural killer cells, do undergo subtle shifts in their ratios. Critically, we see a genetic shift toward an increase in M1 macrophages.
What are M1 macrophages?
Macrophages are the frontline soldiers that eat debris, but the M1 subset is the highly aggressive, shoot first, ask questions later, pro-inflammatory type. This microscopic shift explains perfectly why that red line on the graph can get so violently out of control if active disease is present. The older body is biologically primed with aggressive M1 cells to overreact to the bacterial threat.
Wow. But I want to focus intently on that third bullet about nutrition, folate, vitamin B9. In a highly technical slide about macrophages and cytokine receptors, mentioning a simple vitamin feels so incredibly specific and actionable.
It is incredibly actionable, and it is a massive oversight in a lot of traditional clinical treatment. It leads directly into the core clinical tip on this slide.
The clinical tip reads, always screen for nutritional deficits like folate and systemic inflammatory burden, like elevated CRP in older periodontitis patients.
The biochemical connection between a patient's daily diet, their systemic inflammation, and their localized oral health is profound.
Yeah.
When we see an older patient whose periodontal disease is suddenly rapidly progressing despite decent hygiene, we shouldn't just lazily assume it's because their tissues are old.
Right, you have to dig deeper.
We must act as systemic detectives.
We need to look at the whole integrated system. Are they eating a varied, highly nutrient-rich diet? Often, older adults face hidden challenges with nutrition. Maybe their worn teeth mean they can't chew fibrous vegetables as well, or they're living alone and preparing much simpler, less nutritious meals.
Why folate specifically, though?
Because folate is absolutely essential for DNA synthesis and cellular methylation. If their serum folate drops, the rapidly dividing epithelial cells in their gum tissue physically lose their ability to replicate and repair the constant microwounds effectively. The breakdown in the mouth is very often the canary in the coal mine, signaling deep systemic nutritional and inflammatory collapse. So if you're a clinician treating an older patient, you are absolutely not just a tooth carpenter mechanically scraping roots. You have to be a holistic systemic physician. You have to ask about their daily diet, their living situation, and ideally, their recent blood lab work. Now, coming to the next slide.
We're getting to the absolute climax of the masterclass's clinical argument here. We're going to put the actual mathematical risk factors head to head.
Slide 12 is boldly titled Progression of Disease, the True Risk Factors. And the central visual is a shocking bar chart comparing odds ratios side by side. On the far left, there is a tiny, almost invisible dark blue bar labeled Age Risk, odds ratio 1.24. Right next to it is a towering, massive, screen-dominating red bar labeled Poor Oral Hygiene, odds ratio 20.52.
To appreciate the gravity of this, let's quickly contextualize what a statistical odds ratio actually represents in medical literature.
Please do.
It's a mathematical measure of association between an exposure and an outcome. An odds ratio of exactly 1.0 means there is absolutely no statistical effect. An odds ratio of 1.24 means that just the pure act of being older gives you a very, very slight, almost imperceptible increase in your statistical odds of having progressive disease.
So it's basically nothing.
It is almost mathematically negligible. But an odds ratio of 20.52, that is astronomical in the medical sciences. To put that massive red bar in perspective, the widely cited odds ratio linking heavy chronic chain smoking to the development of lung cancer is often in the 15 to 30 range.
Wow. So, mathematically speaking, poor daily oral hygiene is as strongly violently linked to the destruction of your jawbone as heavy chain smoking is linked to getting lung cancer.
Precisely. The statistical math is undeniable and brutal. That towering red bar proves definitively that what you do every single morning and night with your toothbrush and floss is infinitely more impactful on your tissue survival than the chronological year printed on your birth certificate.
But as always, biology has nuances.
Right.
And there is a caveat text box here that seems to offer a slight counterpoint to that narrative. It's called the experimental gingivitis caveat. I'll read it. When older subjects, 65 to 80 years, abstain from oral hygiene, they develop more inflammation faster than younger subjects. So wait, I have to pause and look at this critically. Doesn't that explicitly prove that age is a major contributing factor? If they develop clinical inflammation faster when they start brushing, their older senescent immune system must inherently be to blame.
It is a phenomenal nuance, and you're right to highlight the tension. Yes, if you run a clinical trial where you take a healthy 70-year-old and a healthy 20-year-old and tell them both to stop brushing their teeth entirely for 3 weeks, the 70-year-old's gums will become red, highly swollen, and bleeding much more rapidly than the 20-year-old's.
Why?
Because of those slight immune shifts we decoded on the last slide, the inherently increased baseline of pro-inflammatory cytokines, the higher concentration of aggressive M1 macrophages. Their older immune system is primed on a hair trigger to react more violently to the sudden massive buildup of bacterial plaque.
So the resultant fire starts faster because the highly flammable dry brush has already been laid out by the aging immune system.
Exactly. But, and this is the crucial paradigm-saving but that leads directly to the final verdict on the slide, the severe inflammation only happens if they stop brushing. The age-related trigger-happy immune shift only matters, it is only weaponized, if the plaque is allowed to accumulate and initiate the cascade.
Let's read the verdict. It says, age is merely a background or associated factor, not a true causal risk factor. Plaque, smoking, and genetic susceptibility are the overriding determinants of severity.
Age is merely the physical canvas. Plaque, smoking, and systemic genetics are the paint. You simply do not get a destructive picture of severe periodontitis without heavily applying the paint, no matter how old and weathered the canvas happens to be.
And the exam pearl emphatically locks it down for the boards. Is age a primary risk factor for periodontitis? False. It is strictly an associated background factor. Now coming to the next slide.
So we have exhaustively proven that the tissue damage isn't inevitable and that hygiene trumps age. The final, most pressing clinical question remains. If an older person does have severe disease, can we still physically intervene and fix it? Or is their altered, dense, fibrous tissue simply too old and exhausted to respond to modern treatment?
Slide 13 answers that existential clinical question definitively. It's titled, Response to Periodontal Treatment. We have a very clear timeline graphic comparing two hypothetical patients side by side. The top timeline is a 30-year-old patient. The bottom timeline is a 70-year-old patient. Midway through both timelines, indicating clinical intervention, there's an icon of a sharp dental instrument labeled Scaling and Root Planing, or SRP. At the end of both distinct timelines, the outcome arrows point to the exact same identical green checkmark text, identical healing and attachment gain.
To set the stage, scaling and root planing is the clinical technical term for what patients often call a deep cleaning.
Right.
It's an intensive non-surgical procedure where the clinician uses specialized ultrasonic and hand instruments to go deep below the gum line into those dark pockets to meticulously scrape away and utterly debride all the hardened, calcified calculus and the toxic bacterial biofilm from the root surfaces. Remember that lumpy, irregular cementum in the resorption bays we talked about?
Yeah, the swamp.
Right. They're physically scrubbing out the swamp to reset the local ecology.
And the graphic unequivocally says that if you perform that exact same meticulous physical procedure on a 30-year-old and a 70-year-old, the resultant biological healing is identical. Let's read the bottom line text. Despite all histologic changes, there are no differences in response to non-surgical or surgical periodontal treatment between young and old patients. Healing capacity remains fully intact, provided meticulous plaque control is maintained. Without plaque control, disease progression may accelerate with age.
This slide is the triumphant, immensely optimistic culmination of everything we've meticulously looked at today. Think about it. Despite the flattened REIT pegs making the tissue physically weaker, despite the dense, coarse, highly insoluble CDI collagen refusing to break down, Despite the significantly decreased fibroblasts in the periodontal ligament, despite all of that microscopic wear and tear, the fundamental biological machinery required to execute the wound healing cascade is completely unaffected.
That's incredible.
If the clinician manually removes the pathogenic threat, the plaque, and the calculus, and the patient maintains hygiene, the body's incredible homeostatic drive violently takes over. The tissue heals, the inflammation subsides, and the gums physically reattach to the root surface with the exact same vigor and statistical predictability in a septuagenarian as they do in a millennial.
It's so deeply optimistic. It means the fight is never lost just because of age. And right here, there's a bright yellow box with the ultimate trick question. I'm going to ask you, the listener, right now, as if you were sitting for your board exams. How does advanced age alter the expected clinical attachment gain after SRP?
Say the answer loud for the people in the back.
It doesn't. It doesn't alter the expected outcome one microscopic bit. The underlying physiological healing capacity is fully, beautifully intact. Now coming to the next slide.
Okay, we have triumphantly established that the cellular biology is sound. But the reality of treating a living, breathing human being in a clinical chair is not just about treating their microscopic tissues in a vacuum. We have to look at the whole person and their systemic reality.
Slide 14 brings us firmly back to reality. It's called clinical management and maintenance. Across the top, there are 3 distinct icons representing the real, practical hurdles clinicians face every day. A drawing of a brain, prominently labeled cognitive decline. A drawing of an arthritic hand, labeled reduced motor function. And a drawing of a tooth with dark, decayed spots near the root, labeled root carries risk.
This slide brings a very necessary, deeply empathetic dose of human reality to our biological deep dive. The periodontium, the gums, and the alveolar bone might be perfectly histologically capable of healing, as we just proved, but the complex human patient attached to those gums might be facing massive, overwhelming systemic life challenges that make our clinical job significantly harder.
Let's read the real challenges text to see how this plays out. It says, difficulties in periodontal management rarely stem from local tissue aging. Instead, they arise from systemic aging effects that compromise the patient's ability to maintain home plaque control or increase collateral risks like root caries.
We have to practice empathy here. If a patient develops severe rheumatoid arthritis in their hands, reduced motor function, they physically cannot manipulate a thin piece of string floss or hold a manual toothbrush at the highly specific, demanding 45-degree angle required to clean those critical gingival margins.
Right. It's a physical barrier.
The plaque inevitably builds up because the mechanical tool has failed them. If a patient is tragically experiencing Alzheimer's or general cognitive decline, they might simply forget to brush entirely or lose the complex executive function required to maintain a multi-step daily oral hygiene routine.
And what about the root caries?
Regarding root caries, which is the clinical term for rapid, devastating cavities forming directly on the exposed root surface, older patients often suffer from polypharmacy. They are taking multiple systemic medications for blood pressure, heart conditions, or depression, and the primary side effect is severe dry mouth.
Less saliva.
Exactly. Saliva is a powerful mineralizing buffer against acid. Less saliva means radically less protection against the acid produced by plaque bacteria, leading to shockingly rapid, catastrophic decay on those exposed, softer cementum roots.
So the true hurdles to keeping an older patient healthy are deeply mechanical, behavioral, and pharmacological, not histological. But there is a wonderful, highly encouraging section here called the silver lining. I'll read it. Clinical studies demonstrate that older individuals often show greater compliance with supportive periodontal maintenance therapy schedules than younger patient cohorts.
I love that this masterclass included this point. It highlights the positive human element perfectly. Older patients, generally speaking, are often far more deeply invested in preserving their baseline health. They acutely value their teeth because they intimately understand the grim, systemic consequences of losing them.
So they actually show up.
And quite simply, they show up. They reliably make their 3-month maintenance appointments. They are often incredibly diligent, highly motivated, and receptive partners in their own healthcare, often far more so than a busy 25-year-old who might feel biologically invincible and casually skip their cleanings for 3 years straight.
That is a phenomenal grounding perspective. The clinical tip at the bottom wraps this empathy up into an actionable directive. Treat the patient's manual dexterity, cognitive baseline, and systemic health, not just their chronological age. It's a clarion call for customized, highly empathetic care. If they have arthritis, don't just yell at them to floss better. Recommend a sonic electric toothbrush with a large, grippable handle or a water flosser. If they have dry mouth, prescribe high fluoride toothpaste, work intimately with their physical reality. Now coming to the next slide.
We have reached the final slide of the masterclass. It's time to pull all of these complex microscopic threads together into a unified clinical philosophy.
Slide 15 is the grand finale, titled The Ultimate Synthesis. It features a massive overarching circle at the very top labeled Aging Periodontium, and 3 thick arrows branch down from it into 3 final foundational pillars of clinical truth. Let's read through these final pillars one by one to lock this all in.
Let's do it. This is the ultimate takeaway.
Pillar 1 is biology changes. The concluding text reads, cementum thickens 5 to 10 times, collagen becomes denser and insoluble, REIT pegs flatten, and OPG rises to balance Ray and Kal-El.
This is the unflinching acknowledgement of physiological reality. The local tissues do undeniably transform over 80 years. The cellular factories alter their output, the structural proteins cross-link and stiffen, the undulating anatomical borders smooth out and become vulnerable.
But they adapt.
But crucially, the brilliant evolutionary chemical defense systems, like the massive surge of OPG, rise precisely to meet the inflammatory challenge, maintaining a perfectly balanced homeostasis. The structural changes are very real, but they are inherently adaptive, not inherently self-destructive.
Pillar 2 is pathology is cumulative. The text reads, long in the tooth is a myth. Recession and attachment loss are the math of time plus trauma or plaque, not a physiologic guarantee.
This is the definitive dismantling of the cultural idiom we started with. We have methodically proven that if you protect the biological tissue from the raging storm of bacterial inflammation and harsh physical trauma, the gums will stay right where they belong, and the jawbone will maintain its robust height indefinitely.
So all that damage is just accumulated trauma.
The devastating damage you see in an older mouth is simply the visible archaeological record of the daily microbattles fought over decades against bacteria and aggressive habits. It is a historical log of trauma, not a ticking biological time bomb.
And finally, Pillar 3 is treatment works. The text reads, age does not preclude success. Histologic shifts have negligible impact on clinical healing from SRP or surgery.
This is the ultimate clinical triumph. It doesn't matter one bit that the collagen is coarse or that the cellular turnover has mathematically slowed down. If active disease is present, the clinician can absolutely intervene, manually remove the bacterial cause, and completely rely on the body's innate, perfectly preserved ancient capacity to heal itself. We can aggressively save the teeth and restore health, completely regardless of the patient's chronological age.
And at the very bottom right of this final slide, there's a small, satisfying box that says, system check complete, end of review. You have mastered the clinical and histologic dynamics of the aging periodontium.
A very, very well-deserved congratulations to anyone who's stuck with us. To walk through that intense level of microscopic histological detail, process the complex cytokine pathways, and come out the other side with a clear, highly optimistic clinical philosophy is no small feat.
It has been an absolutely incredible, mind-expanding journey. We started an hour ago with this deeply ingrained, almost culturally depressing idea that our human bodies just inevitably, predictably fall apart, that getting long in the tooth is just an unavoidable tax we all have to pay to the passage of time.
And we completely debunked it.
But what we've discovered layer by layer is an incredibly empowering, scientifically verified realization. Our bodies are constantly, desperately adapting. They are constantly balancing, just like that OPG and Kiel scale, throwing up massive chemical defenses to try and protect us from our own environment.
They fight for us every day.
And even more amazing, beneath the denser collagen and the flattened REIT pegs, they remain utterly, stubbornly ready to heal and rebuild if we just give them the right, clean environment, completely ignoring the calendar year.
The human biology is fundamentally resilient. It is our job as patients to respect it, and our job as clinicians to meticulously protect it from the cumulative insults.
As we finally wrap up this deep dive, I want to leave you with a final, lingering, provocative thought. We just spent all this time mathematically and biologically proving that gum recession and tooth loss are actually the preventable math of time plus trauma rather than a biological clock winding down. If that is proven to be true for our mouths, it makes you pause and wonder, what other major physical changes in the human body do we passively, lazily accept as just a normal part of getting older that are actually completely preventable results of accumulated, untreated microtraumas? What else could we functionally preserve for a lifetime if we just stopped blaming the calendar?